from Bogota, Colombia, concerning the pulmonary infection diseases. I want as well to say congratulations for this initiative, which is the Lungs Day. And it's to me a pleasure to introduce you the next speakers and lectures. The first one, as you can see in your program, is the Dr. Ignacio Martin Lesch. He's a consultant in intensive care medicine.
Here we are. So hello, how are you to everybody? So I would like to first congratulate the organization for this initiative. It's quite interesting, and I'm going to talk for the next 50 minutes about the tools for outcome prediction in patients with community-acquired pneumonia. So the first is that when we are trying to understand what is the research in community-acquired pneumonia, the next steps, this is a manuscript that I had the pleasure to co-author with Professor Torres that is going to talk after and Menendez in Valencia. So we were talking about one of the most important developments that we have to do for the next year. So there is a need to increase the knowledge of tools for outcome prediction. So the problem is sometimes when we are trying to analyze the mortality in community-acquired pneumonia, I think that it's important to distinguish that when we are talking about intensive care medicine, community-acquired pneumonia, so the mortality could be as high as 40%. And this is not only 40%, but because we have a range of severity from sepsis to severe sepsis and septic shock. So now we have new definitions that we will discuss a little bit after. But we see that the mortality in patients with community-acquired pneumonia could rise up to 50% of them. At the same time, we know that patients that they are coming with community-acquired bacteremia, that as you can imagine, many of them, they are coming with a community-acquired bacteremia induced by a community-acquired pneumonia. The mortality in the last years is decreasing because I think that we are doing good things and we are implementing a better in the ICU and in the hospital, especially detection. So what we actually need to do is to have clear definitions, because the true cases of sepsis that we are going to have the problem of missed cases, because we can increase the death in this patient because we are going to have a delayed therapy. When we are in the other side, overdiagnosis, we are going to overuse resources. We are going to increase the risk of death due to delayed therapy and the always problem of antibiotic resistance. So, and one of the most important issues in the last years is that when we try to analyze the mortality in studies that they have been analyzing, for instance, different procedures like protein C or resuscitation purposes, so we see that the mortality could be very, very different from one study to the other. So we really need a good definition, especially for enrolling into clinical trials. This is a survey that we did conduct with the European Society of Intensive Care Medicine through the through the sepsis and inflammation section. So in 2014, so when we ask about which is the detection that we do have in patients with sepsis in general, not focusing in community-acquired pneumonia, we see that the temperature is still, something that the vast majority of the responders were acknowledging. So we see that, as we can see, there are many signs and symptoms that we consider when we are going to detect and we are going to recognize sepsis in patients admitted to ICU. And one has been under a lot of discussion and is actually something that is not very well analyzed in community-acquired pneumonia, that is the impact of lactate in patients with sepsis. That is now one of the new definitions in the sepsis 3. So when we are moving about the severity and the outcomes, we are going to probably talk briefly about different scores. This is a well-known score, that is a CURB 65 score, that it is including confusion, urea, respiration, blood pressure, and the age. And as you can see, it's very, very interesting to detect that this is very familiar with something that we have in the new definition, that is trying to understand that pneumonia is not an infection localized to the lungs, but is a systemic disease. So here you have a comparison about the curve 65 and what is happening with the new definition, that is in this case is the Q-SOFA. And as you see, there is a lot of similarities with this new definition. So probably there is not too much done in the sepsis world, and especially for community-acquired pneumonia. There are not many studies, and I would like to highlight this study again from the group of Tony Torres, that they did analyze almost 7,000 patients, and they did check the performance of Q-SOFA, curve, the modified SOFA, curve 65, and the PSI. And as you can see, the performance is quite different because we are going to have different questions. So if we are trying to discriminate, or we are going to try to have a good sensitivity, specificity. So probably there is not a good score in one or the other regard. So it's probably the kind of question that we are going to do. I like it very much, this paper, and I wanted to share with you all because I think that, you know, include a very good algorithm of initial assessment or further assessment and how you are going to place the patient in one side or in the other. So I think that, you know, this is a nice paper showing that probably there is no one score, but different tools for outcome in different settings. So when we are trying to talk about community-acquired pneumonia, also we need to take into account the famous triangle, classical triangle. So the pathogen, the host, and the treatment. And I'm going to talk briefly, because of the matter of time, about a few things in this triangle. And the thing is that we know that cytokines are going to be associated with the infiltrates that we have in patients with community-acquired pneumonia. As you can see, this is a classic paper from Glynn showing that patients with community-acquired pneumonia, they had elevated IL-6 levels. So we did perform with IL-6 and study with Tony Torres in the group of patients from the hospital clinic, that we can see that IL-6 was a very good biomarker trying to distinguish which is going to be early and late and treatment failure in general. So I think that IL-6 was a very good biomarker. That unfortunately is a biomarker that is not being used in current clinical practice. We are using other biomarkers, but IL-6 had a very good signal. So what about the enrollment in clinical trials? And I wanted to bring this paper because I think that in the last years we have had some studies trying to show the benefit of using of coadjuvant treatments. So for instance, immunoglobulins in patients with community-acquired pneumonia. This is a manuscript that we published this year in Annals of Intensive Care, so that we did analyze in patients with sepsis, and as you can imagine, the vast majority of them, they were patients with community-acquired pneumonia, so that the mortality, depending on the levels of immunoglobulins, is going to be totally different depending on the organ failure of the patient. So as you can see, patients that they have a low severity, so they have a low SOFA, so they are going to distinguish very well when there is a high or a low immunoglobulin subclase. This is important because probably patients that they have an advanced organ failure should not be randomized and probably include in clinical trials. So I'm going to move briefly to the treatment of community-acquired pneumonia, because we see that we have several trends about the use of antibiotics, but unfortunately we need something else with the addition of the antibiotics. This is an editorial that came into account when the Protein C paper was published, that I like it very much because I think that it does summarize very well the use of coadjuvant therapy. And we see that the antibiotic is still the most important part in this treatment. So at the same time, as I said before, we know that we have patients that even with adequate antibiotics, when they are shocked and they have an advanced organ failure, antibiotics are not going to be maybe enough. So what about which kind of antibiotics are we going to use? I think that, you know, it is important to distinguish that in the guidelines we have the use of beta-lactamase inhibitor with penicillins, with the use of azithromycin or a fluoroquinolone. This is the recommendation. So there are several good evidence about the combo of antibiotic therapy in patients with community-acquired pneumonia. We see this paper from Grantwater showing that the combo therapy was superior to a single effective therapy. This is not a very high, is a paper with not many patients, but it was done in 2001 and opened the knowledge for the combo therapy in community-acquired pneumonia. As you can see, the next paper from Badur that was published in the Blue Journal, we did have the same when the patients, they have community-acquired pneumonia, because the paper from Water was including mainly patients with bacteremia. So after this paper, we had another that they were analyzing the impact of combination therapy in patients with shock. And as you can see, there is a signal that the use of combination therapy was beneficial in patients that they were shocked. This is part of the Capucci study. It's a Capucci consortium that was conducted in Spain. So what is happening when we analyze patients with bacterial pneumococcal pneumonia, as Grant Water did? This is a cohort of 400 patients that they were coming from Spain, and you see that the use of macrolides was also associated with a protection benefit. So what about atypical pneumonia? As you can see here, the use of quinolones and macrolides, when they are added one to the other, the outcome is going to be much better. So, and in terms of combination, which is the combination that we are going to provide? So there are several papers showing and trying to analyze if the combination with macrolides or quinolones was better. And you see that in this paper coming from Antonio Ansueto's group, we see that the use of fluoroquinolone was not associated with increased survival. So maybe protection is not due to a fluoroquinolone atypical coverage in these patients. I liked this paper very much that was coming also from Ansueto's group, that we can see that patients that they were receiving macrolides, they were doing better than those that they were receiving other kind of combination. But the most important, and I would like to focus on the part on the right hand side of the slide, we see that patients with macrolide resistant severe sepsis, they had a better outcome. So probably there is an immunomodulatory effect with the macrolides in this patient. So there is an important signal. And finally, we did conduct this study. This is an observational study that was done in many units in Europe, that we did analyze the performance of the guidelines. That was the first study to try to analyze if patients that they were receiving macrolides versus quinolones were showing any benefit. And as we can see, the benefit in the overall population was not adequate with quinolones compared to macrolides, but we can see that the use of macrolides was associated to better survival. So this is a summary of all the studies that have been conducted, and we can see that the use of macrolides is a good therapy for combo therapy in patients with community-acquired pneumonia. So we have to acknowledge that the vast majority of these studies are observational, because the ones that they have tried to be done have been only done in non-clinical ICU settings. So finally, I would like to say that there are many studies, and this is one of the meta-analyses showing with more than 10,000 patients that this association remains very significant. So I'm finishing my lecture. So I would like to say that consider community-acquired pneumonia as a systemic disease. I think that is important for outcomes and for tools for detection and discrimination is not the same. And I think that this is, in my opinion, important. To the best of my knowledge, the use of combo is the right thing with the use of macrolides, and outcomes are not just mortality. So I would like to pass on the moderator for continuing with the session. Thank you very much.
Thank you very much for the lecture, Dr. Lech. We are going to introduce you Dr. Antoni Torres. He is professor in the medicine at the University of Barcelona. He is a physician of reference nationally and internationally in lung infections. And he is going to speak to us about steroids for acquired pneumonia, why, when, and how. Go ahead, doctor.
So again, I will go ahead. Thank you very much for this initiative that I applaud a lot. And thank you for the whole work that the organizers have done on this. So I'm going to summarize for you if steroids should be used in community-acquired pneumonia or not. And these are my conflicts of interest. I have no conflicts for this talk. Severe cap at our institution, and as you can see here, in patients with invasive mechanical ventilation plus shock, 38% mortality. This is an unacceptable mortality. And mortality is related to the persistence of systemic inflammatory response. In this slide from this paper published from a group of Barcelona, you can see that patients with persistent levels of inflammatory markers such as interleukin-6, interleukin-10 had a poor outcome compared to the patients with, there was a decrease of these markers. So for that reason, authors have tried to use anti-inflammatory molecules as adjunctive therapies in community-acquired pneumonia. And one of them is definitely corticosteroids. The rationale is that they decrease the local and systemic inflammatory responses. Okay, then we confirm in humans that the inflammatory response is decreased both in BAL and in serum, in severe pneumonia in patients receiving corticosteroids. Then, in addition, we have developed several animal models of severe pneumonia in mechanically ventilated patients. One of them is now the Streptococcus pneumonia model using a serotype 19A, and we are studying this model with corticosteroids plus antibiotics. Years ago, with Carlos Luna and also Charles Marquette, we performed this study. "72 hours mechanically ventilated." And then this is the schema of the study, and we compare control group, ciprofloxacin group, and ciprofloxacin plus glucocorticosteroids. And then we sacrifice the animals at 96 hours. What we observe is a decrease in the bacterial burden in animals receiving the combination of ciprofloxacin plus glucocorticosteroids. So at least we observe that using corticosteroids, there is a decrease in the lung bacterial burden. Well, this is a summary of the meta-analysis about corticosteroids. There are 9 meta-analyses. The problem is that many of them share the same or part of the studies, the same studies, and the last is in 2016. It's published in Clinical Infectious Disease, and this is the only meta-analysis with using individual data. Overall, we can show that most of the studies, there is a decrease in the length of stay and a decrease in the time to clinical stability when using corticosteroids compared to stay in 1 day, decreased time to clinical stability in 1.5 days, and decreased mortality in severe community-acquired pneumonia in most of the studies. But there are pitfalls in many of these studies included in the meta-analysis. One is the inclusion of non-severe community-acquired pneumonia, heterogeneity in the definition of severe CAP, initial systemic inflammation not taken into account, and heterogeneous corticosteroids dosage and duration. We performed this trial with important particularities. This was published in JAMA 2015. We only included severe CAP patients. We only included patients with a high level of CRP, higher than 15 milligrams per deciliter, and we used this dosage, 0.5 milligrams per kilo per 12 hours, every 12 hours, and compared to placebo, only for 5 days without tapering and stopping after 5 days. And the endpoints of the trial were different from compared to the classical endpoints. We included early failure defined by development of shock, need for invasive mechanical ventilation, or death within 72 hours of treatment, or a composite outcome of late treatment defined as radiographic progression, as you can see in these two chest X-rays, persistent of severe respiratory failure, development of shock, need for invasive mechanical ventilation, not present at baseline, or death between 72 hours and 120 hours. These are the main results. We observed a decrease from 31% to 13% in treatment failure. And when we examined the different components of treatment failure, this signal was more evident in late treatment failure and mainly for radiographic progression and late septic shock. There were no difference in mortality, or the percentages were different in favor of corticosteroids in the ICU mortality and in the hospital mortality as well. These results were confirmed in logistic regression analysis. What has to be clarified in this issue of corticosteroids in severe CAP? So the potential side effects. This is again the summary of meta-analysis. 5 meta-analyses found increased risk of hyperglycemia. In 2, the risk was similar. In 3, was not searched for. In 6, gastrointestinal. Here, in an ex vivo culture model of human lung tissue, Hocke and colleagues, this is in personal communication, found that the infection with strep pneumo completely blocked dexamethasone regulated genes, indicating bacterial inhibition of glucocorticosteroids. How corticosteroids act. Well, and he said that the two logical explanations for radiographic progression are uncontrolled pneumonia and development of acute respiratory distress syndrome, and that corticosteroids could act in that. And he postulated or hypothesized that the Harris-Alzheimer-like reaction could be another explanation, blocking the inflammatory response that is observed when you administer bactericidal antibiotics. These are the dosages observed in several studies. There is a range from 5 in our study to 9 days in another one. But in the meta-analysis of NIE, he found that 7 days probably is the best. See better histopathological signs when combining clarithromycin with dexamethasone compared to placebo or potentiated with macrolides or not. Do we need additional trials? But probably yes, because the populations are small. The inflammatory status is not considered in most of the studies. A lot of severe CAP non-inclusions, and we need to...
Hello. Thank you very much for your lecture, Dr. Torres. Thank you very much indeed. And we are going to proceed with the last lecture from this session, number 4, with the Dr. Andre Khalil from the United States, professor at the Internal Medicine Division in Infection Disease at the Nebraska Medical Center of Hammond, Nebraska. And he's going to talk us about the management of adults with hospital-acquired pneumonia, associated pneumonia. I was introducing Dr. Andre Khalil concerning his lecture, Management of Adults with Hospital-Acquired and Bacterial-Associated Pneumonia. I don't know if he's in leave.
All right. So this is Andre. Thanks, Pablo and the organizers for such an incredible day. I apologize for my voice. I got a upper respiratory infection. Ironically, I got a laryngitis. So just bear with my voice. So this is the group of the panelists that worked together for the last 5 years in order to put this together. So I just want to give credits to all the guideline panel members that worked very hard to get this accomplished and published last year. I have no conflicts of interest related to the subject. So just since we have such a short time frame, I'm going to just go through some of the most critical points of the guideline. The first one is all the panelists believe that after a very thorough literature review of all the HCAP, that HCAP should be removed from HAP and VAP guidelines. That was a major and very important decision because there was so much controversy about the validity of this definition. And so once the review indicated that HCAP was a very poor definition to define multi-drug resistant, the presence of multi-drug resistant bacteria, and also HCAP was a very poor definition to define the prognosis of these patients. It was very clear that it did not belong to the HAP and VAP, and we asked the CAP committee to reevaluate that to see if there is any utility of the definition for the CAP, and this is what's being done now. So the next couple of slides about the multiple biological methods. The first question was if, what type of diagnostic methods should be used. We did a very extensive review of all the data, both from randomized trials and observational trials, and it became very clear that recommending a distal collection of respiratory sampling would not really benefit the vast majority of the patients. We could not detect any benefits in terms of survival, any benefits in terms of ICU stay, any benefits in terms of mechanical ventilation duration, and that became very clear. The second part of the story was obviously the first one is to see if the invader procedure would make a difference, and we did not detect that. Second part is that the panel felt very strongly that now with much more data about the effect of delaying antibiotic use for to do procedures potentially would be more harmful than beneficial to most patients. We know from both severe sepsis, septic shock, and including a large population of patients with pneumonia in these trials, that for every hour that you delay antibiotics, you can really increase the risk of mortality in this patient. So doing these procedures potentially would even lead more kind of the risk of mortality that we would see without doing the procedure. And the last thing was the risk associated to the procedure itself. The more invasive you are, the more side effects you're going to have from any procedure, including bronchoscopy. So it became very clear that that would not be the recommendation for most patients. That being said, the second question, as you can see now, is that if the patient has a bronchoscopy done or a quantitative analysis done or an EBL done, how are you going to evaluate these results? And the results definitely can have some utility in terms of removing, de-escalating, or stopping antibiotics if the results are below the cutoff. So this is something that, again, you can see as a very low quality of evidence. It was not a strong recommendation anyways, but if you have this data, it can be a data that can help you to de-escalate these patients as well. The next step that we took was to evaluate the biomarkers and clinical scores. And we looked into many more biomarkers and clinical scores than you see here, but these are the ones that made the final list of the guideline. CRP, PCT, and TREM1, and CPIS, that it was a consensus of the panelists to go further with the literature review. And as you can see, the recommendation, the data was very clear that none of these biomarkers really can help us to change the outcome of these patients or to improve the diagnostic capacity that we have in the bedside, including the clinical scores. We went very thoroughly in each one of these factors, and we just could not really justify the use for them in terms of diagnostic approach for these patients with HAP and VAP. The next thing that you're going to see that's quite different from the 2005 guideline is the reevaluation of the risk factors. I think this is really a critical point of this guideline, because these are factors that have a lot of clinical intuition and has a lot of scientific backup as well. As you can see, the risk factors that were clearly associated with MDR-VAP would be the prior IV antibiotic use of 90 days, and this is very important. We're talking intravenous because a lot of other guidelines before, including opinion papers, editorials, and reviews did not emphasize too much the intravenous use, but here we emphasize very much because all the data that is associated with the higher probability of MDR is associated with the intravenous antibiotics. It's not only an antibiotic. It's not only like taking some quinolone as an outpatient. We're talking about true use of intravenous antibiotic in the last 90 days that's required for a specific disease process. That was the strongest of all. As you can see, that was the strongest factor for pretty much all the subsets, both MDR-VAP, MDR-HAP, MRSA, VAP, and HAP, and Pseudomonas, HAP, and VAP as well. That was the most consistent risk factor for all. But then we had 4 other risk factors for MDR-VAP that included 5 or more days of being hospitalized, and 3 that were very much associated with disease severity, septic shock, ARDS, and acute renal replacement therapy. So next, we'll talk about therapy, and one recommendation that was consensus among all the panelists that I think really makes it a huge difference compared to any other review before is that we recommend, recommend means a strong word based on a great system. This is really, I strongly recommend that hospitals and units do local antibiograms. This really can help both all the healthcare providers and the patients to have the best antibiotic therapy once they get started, because as you know, most of us will start empirically without having any data, and the data is going to take 1 or 2 days for you to get. So once you have, the data about the prevalence of your floor in your hospital, in your unit, the chances that you're going to get the right antibiotic are much better. And as I know that the more appropriate antibiotics are started early, the better the survival is going to be of all these patients. Then, in terms of a general microbiology coverage, Staph aureus, Pseudomonas were high in the list, obviously, because we're talking about when patients usually are, having VAP or either severely ill or have risk factors for MDR. And besides risk factors that we talked before in the slide before, as you can see in the last sentence of this slide, if you have a hospital prevalence with high prevalence of Staph aureus, these patients, especially with methicillin-resistant Staph aureus, you should be covering for MRSA as well. And we recommend either vancomycin or linezolid as drugs of choice. I'm not going to talk about pathogen-specific therapy because we don't have time for each one of these pathogens, but there was absolutely no clinical cure difference or survival difference between vancomycin and linezolid in a more thorough pathogen-specific review. And one thing that's important is if you don't have a high rate of MRSA, and we suggest that in these patients with VAP in the ICU, you should have at least minimal coverage for MSSA. Either you can keep some of the gram-negative coverage, like protease, cefepime, levo, imipenem, meropenem, all of them will cover the MSSA. Or if you don't have any high suspicion for gram-negatives, you can use the more standard therapy for gram-positive infections like oxacillin, lefcillin, and cefazolin. Just because of the time, I'm going to just keep going with the next slide. We have so much to cover, but we do not suggest aminoglycosides along with this patient. It's important because the data is suggestive that this type of class of antibiotic cannot really take care of these patients, both because of the blood levels as well, and the parenchymal levels as well. And really try to avoid any of the other toxic drugs if you have other available drugs with you. This slide is just to give you a little bit of the rationale for the panelists to choose the prevalence threshold of 10 to 20% for MRSA and then of the, kind of this combination versus single therapy. And this is important because, we're talking about MDR risks, is that we all sometimes have the feeling that the better. And, when you look at the data, even if you use 3 or 4 antibiotics, you will never reach 100% chance in every patient that you see them. It doesn't matter how many antibiotics you give this patient. So I think it's very important that the ceiling effect is something that it is a limitation for all of us clinicians treating these patients. And that's part of the reason why we chose the 95%. I'm not going to go through the tables of antibiotics because all of you have access to the free access to the IDSA and ATS sites for all the antibiotics. But suffice to say that all the antibiotics are based on the risk for MDR versus no risks for MDR for these patients. And just to conclude the VAP part before we go to the HAP, this is a summary of the choices that you have when you analyze these patients. When you have these patients on a bedside and you're evaluating these patients, there are 3 really factors that will be, very, very important for you to decide how to approach treatment of VAP. So you're going to have the immunological factors, you're going to have the local antibiogram, and you're going to have the disease severity. So it's a very intuitive, very clinically intuitive approach. And I think this is the beauty of these guidelines in the sense that brings to the bedside something that we are already doing, something that really combines clinical skills and data-driven evidence as well. So now we switch to something that also is a little bit different from previous guidelines in the sense that we try to separate our understanding of the no antibiogram is probably more critical here than it is for any other situation. And so for these patients, we recommend the coverage for Staph aureus as a regular approach. It could be MSSA or MRSA, depending on the prevalence of your hospital. So if you have a risk factor, let's say prior intravenous antibiotic compared to VAP, and again, we did a lot of prevalence data and meta-analysis data in terms of trying to analyze the microbiology source of this patient. It's very clear that patients that have HAP without HAP have a much lower prevalence of both Pseudomonas and MRSA as well. So we cannot just go through the data here, but it's something that you can have access to the supplement published with the guideline. Here's a table showing the treatment for HAP, and the drugs are relatively similar, but the approach is a little bit different because we use a different risk of mortality, and we use a different approach in terms of combining versus monotherapy compared to that as well. We spend a good deal of time looking for pharmacokinetic and pharmacodynamic optimization of antibiotic therapy. Still, a lot of data coming out, but based on the data we had available before the publication of the guideline last year, there was already suggestive evidence that you can improve.
You have 2 minutes remaining.
By the use of PK/PD, and was the consensus, even though, again, the data is still growing, not too strong, that you potentially can benefit these patients by the use of PK/PD data. And that include blood concentrations, include extended or continuous infusions or weight-based dosing for certain antibiotics. So all these things potentially can bring some benefits. And interesting enough, right after the publication of the HAP-VAP guidelines, 2 months later, there was a publication by Jason Roberts from Australia doing individual meta-analysis in several studies, randomized trials of severe sepsis and septic shock, showing that actually they obtained a in survival, significant improvement in survival with the use of PK and PD optimization. So that came a little after guidelines, but somewhat confirmed the recommendation we had in the guidelines as well. Close to the end here, the role of inhaled therapy, also controversial with a very, still very much observational data from a situation where you have studies from geographic areas with a lot of resistance and a lot of multi-drug resistant infections. But what we could notice is that through a very thorough analysis of all this data, is that you can actually improve the rate of clinical cure, and there's a trend for improving survival in patients that receive either colistin or polymyxin B, in patients that have absolutely no other options other than these drugs, mostly gram-negative multi-drug resistant infections. So that was a reasonable recommendation as an adjunctive therapy for these patients. To finalize here the length of therapy, there was a lot of gray zone and controversy about length of therapy, years and years, people treating for 7, 10, 14, 21 days. And when you look into the wealth of data from both randomized clinical trials and observational studies, it became very clear that the vast majority of these patients will do well with 7-day therapy. Some of these patients will require less. Some of these patients are going to require a little more. And again, we give the clinician the bedsides to a decision and the flexibility, but on average is going to be around a week for the vast majority of these patients. And and so in the same for HAP, this is for HAP and non-VAP, we found looking at data that would be very similar to the treatment for VAP as well. And this slide is just to illustrate to you why we made these decisions, because when you look into length of antibiotic therapy, we could not find differences in mortality in all these studies, clinical cure, recurrence of VAP. We could not even find different duration of mechanical ventilation. And if you go into our supplements, you're going to see very granular data on analysis of VAP due to non-fermenting gram-negative infections like Pseudomonas, Acinetobacter, Centrophomonas, and still we could not find any clinical relevant outcome that would distinguish, would be improved by the long process of giving antibiotics to these patients. So it became very clear through a multitude of analysis that no clinical outcome really would change with the prolonged therapy. So the recommendation was solidly on the average of about a week of therapy. And finalized, then we analyzed the data on fixed versus escalation, and we suggested that it's time to abandon any kind of fixed therapy. There's no such thing as this is how my mentor did, my professor did, or how I learned how to do it. I've always a 7, always a 9. This is really nonsense. It does not benefit the patients. You have to really follow the patient clinically and make your best efforts to de-escalate in the proper time. And then, so in order to de-escalate, there were several studies trying to use either biomarkers or clinical scores. And the only data that we found suggestive of improving the escalation was with the use of procalcitonin once you're thinking about reducing the amount or the spectrum of antibiotics. And actually, this was based on at least several studies that either were directed to VAP or subpopulations of other studies that use VAP and procalcitonin. And the analysis showed an average of 4 days reduction on the use of antibiotics. And interesting enough, Lancet just came out with a very large individual patient data meta-analysis on the use of procalcitonin that also suggested a reduction of days on antibiotics and also a reduction in mortality on these patients, just published a few weeks ago on Lancet. And we could not find any benefits of CPIS as a clinical criteria to help us to de-escalate antibiotics. Then we did not suggest the use of 4 clinical scores like this to de-escalate. Hopefully we're on time for some questions. Thank you very much.
Thank you very much, Dr. Khalil from the United States. I don't know if one of the physicians from the question team has a question. I can guess that Dr. Ana Laura Gonzalez was hearing us and was in touch with us.
Yes, I'm here.
So you have a question from a question from Khalil?
Yes, the first one was, it's for Andre. Hello. It's about the diagnosis of pneumonia ventilator. I understand the recommendation of not being so invasive with the samples, but I was wondering, why do you choose to put semi-quantitative recount of bacteria to the samples instead of quantitative?
All right, sure. So thanks for the question, Laura. We were, in some ways it becomes intuitive even for myself that most of us like to see the numbers, like to see the magnitude of colonies, and that applies for sputum, that applies for urine, and it's always very enlightening to know a little bit of the magnitude of these infections. But we had panelists going really very thoroughly into all these studies, trying to understand if there was any kind of clinical benefit in patients that had semi-quantitative versus quantitative, and no matter how you cut the data, you could not see the difference. And so it's somewhat frustrating because a lot of us believe that could be something that could enhance our clinical skills and the way that we could potentially treat these patients, but the evidence just didn't pan out, and so we could not reinforce the use of quantitative cultures. The second point, not related to the decision, but as you know, very important as well. There are microbiological laboratories that are very reluctant to use this technique because of they have to have very trained technicians, and it's a very time-consuming process as well. So I've had other laboratories telling me that in other hospitals that they don't want to even do this because it just takes too much of their personnel lab, both in terms of training, education, and time. So it is something that we give the flexibility for you to do. We are not saying that you cannot do it. Just saying that if you're going to do that, you should know that doing that in every single patient, it's not going to per se improve the clinical outcomes of this patient. That's why we had this recommendation a lot.
All right, thank you very much.
Sure.
There goes another for the three presentators. What about the treatment of multi-resistant, extremely resistant bacteria like APC or OXA, and shorten the treatment in that patients that goes well clinically, radiologically, etc., etc.?
Who you want to answer the question? I'm glad to answer, but I can say Tony or Ignacio can answer as well. But since I'm in the phone, I'll tell the guidelines, the IDS-CATS guideline did not address the therapy in MDR patients because the data is incredibly small, very localized in different geographic areas. We really don't know how to best approach these patients. It's all observation, serious. And so whatever we say here, it's going to be much more our opinion. I have patients with MDR Pseudomonas, and I have patients with Pseudomonas pneumonia, resist to everything except colicin, in which I gave short treatment, and some patients I gave a little longer treatment. And honestly, this is all going to depend on how the patient is progressing from your therapy. It's really, I think when you reach a point where you have CREs and XDRs and PDRs, the evidence is going to be much slimmer because it's very hard to do studies in a large sample size with this patient, because these patients are still the minority, thank God, because we don't want a lot of these patients, because otherwise we're going to have a pandemic approach of these MDR infections. Luckily, this is still a small population, but that makes a study of this population much more difficult. So I would say the way I treat them is the same way I treat other patients, in the same in approach that the patient's clinical progression are going to be the dictator of how we're going to approach in terms of clinical therapy. And as we say in our remarks of the guidelines, some of these patients are going to require less, some of these patients are going to require more. But the important thing here is that none of us can come with some magical fixed duration of therapy. Oh, you should give 10, you should give 14, you should give 21, because when you get into a fixed therapy, you're really going to end up giving way more antibiotics than you need for most of the patients. So I think we really have to individualize, and this is the time to individualize our practice.
Nosotros tenemos algo de dudas
We have
y las
some
últimas
doubts,
guías
and
algo
the
confusas
latest
en lo que tiene que ver
guidelines
el
are
tiempo de uso de los antibióticos.
confusing in the time of use of
Usamos el score clínico de
antibiotics.
infección pulmonar o sepsis, usamos la PCT, solo el uno, solo el otro,
We
no nos
use
queda claro.
PST.
Y sobre todo es menos claro cuando
These guidelines
tratamos
are not very
a
clear,
neumonías asociadas al
especially
ventilador.
when we treat pneumonias associated to...
¿Cuál es su opinión al
What is
respecto?
your opinion? We didn't hear what are they associated to. Sorry, there are many noises. Many noises. It's very difficult to hear.
Para Anthony Torres, por favor.
Oh, my question goes to Anthony Torres, please.
So about the duration of antibiotics, I think that the use of Dr. Khalil was presenting the ATS, IDS guidelines. So, but also from the ERS, Intensive Care Society of Intensive Care Society, the European Society of Intensive Care Medicine, and ESNIC and ALAD, we did had a PICO question related to that particular comment, and we did not recommend the use of any particular biomarker, and I think that the evidence to use 7 to 9 days of antibiotics, I think that was sufficient as a recommendation. Also, we consider that for non-fermentative gram-negative bacilli, I think that we can, especially with Pseudomonas, because of the problem of the relapse, and the paper coming from Jan Chastry and many others, and different meta-analyses that we cited in our guidelines. I think that we are really in these particular cases more prone to do more days, close to 2 weeks. So I think that this is our recommendation. So
thank you very much for the answer. Paulo, perhaps you have another question from Madrid.
Okay. I have two questions for Dr. Martin Loeches. I agree with you that CAP is a systemic infection. So, at this moment, it's suitable the use of quick SOFA score instead of cure or fine for screening CAT in order to simplify a score?
Well, the problem with the cube SOFA, I think that is, it's a score that is trying to. It's not a good score for detection, in my opinion. I think that the problem with the quick SOFA is that recognition of sepsis in general and community-acquired pneumonia. I think that probably the use of other scores are going to be more sensitive. I think that we were mixing a little bit the concept with the quick SOFA with other scores. I think that the objective of the quick SOFA was trying to maybe flag better how we were going to analyze the interventions, pre-treat interventions for clinical trials and not for detection of sepsis. So I'm not particularly convinced, we will see, but I'm not particularly convinced that the quick SOFA is going to be a huge advance for community-acquired pneumonia. We have also to consider that there is a nice study that was done by the big German database from Tobias Welke and colleagues, that they did analyze the performance of the curve and the quick SOFA, and if they were really similar. It's not surprising that the curve 65 is taking 3 elements that they are in the quick SOFA, and at the same time we have to say that pneumonia is the most frequent sepsis in a hospital. So this is the reason that I'm not totally convinced about the quick SOFA, but we will see in the next years.
Okay, I have a second question. What is the actual role of the testosterone in CAP?
Is this a question for me?
Yes.
Is a question for Tony or for
you? Okay, or Tony Torres as well.
Well, I think that the use of testosterone is of course a good drug that is we are happy to have in our in our current clinical practice. But I think that the benefit of testosterone is mainly in case that we are in settings with a high incidence of MRSA. Particularly in Europe, MRSA in community-acquired pneumonia is not very common. So depending on the countries, of course, but when working here in Ireland, that it was a problem, in the past, because we had a lot of MRSA similar to what it happened in the UK. I think that there is a huge decrease of the incidence of MRSA community-acquired pneumonia. So this is the reason that we, at the moment, we don't need in our clinical setting. I would like to maybe ask Tony Torres to make a comment about community-acquired pneumonia MRSA and the use of ceftaroline in Spain and other countries.
No more questions?